Before we begin, I'd like to acknowledge the traditional owners of the lands we're meeting on here today, the Wurundjeri people of the Kulin Nation. I pay my respects to elders past, present and emerging. And I particularly want to acknowledge that this always has been a site of technology and innovation and learning. And we absolutely acknowledge that sovereignty was never ceded, and this always was and will be Aboriginal land. Today, I'm awkwardly introducing a fantastic guest, Lisa Garwood-Cross, who is visiting us from the University of Salford. I feel like I should turn that one off because that's kind of weird. And we are absolutely thrilled to have Lisa here today. She has done an extraordinary range of things. Okay, we're joining audio on that one. That's what it is.
Let's see.
Well, not while we're talking here.
No, yes.
Otherwise we'll get feedback. Yeah. So we've had an extraordinary, she's done an extraordinary range of things, from educating nurses to early childhood, to her really interesting PhD research, which was on YouTube sex educators and the ways they do and don't intersect with formal public health and education systems. I am going to let Lisa present her work, and we will have some opportunity for Q&A at the end. Thanks so much.
Throughout this talk, I'm going to draw on a few different research projects. I'm going to give you a quick overview of them before I get on to the juicy, interesting stuff. So the first one, and probably the one I'm going to talk about the most, is a study looking at digital capabilities with nurses, neurology professionals and medical imaging staff in the NHS. So those have been done kind of individually, but all kind of as part of a kind of ongoing process that involved in-depth interviews conducted with nurses and neurology professionals in an NHS trust in the north of England that was aiming to understand their digital capabilities and the barriers to and drivers for the use of digital technology in clinical practice. So we started with nursing and then neurology, and a national study that's ongoing with medical imaging professionals as well doing the same thing. Information network. So this was actually a patient-centered social media intervention designed for and by people living with chronic kidney disease. We call it KIN. KIN works through a series of micro communities run through closed Facebook groups that connect people with chronic kidney disease to others living in their local area. Each KIN group is moderated by patient moderators who maintain links with clinicians who then provide support. And the research that we've conducted, which utilised kind of digital methods and a long-term analysis of KIN, found that the impacts included benefits to access to health information, self-management of chronic kidney disease, and improved well-being due to access to the kind of psychosocial peer support. Then Face Mums is a very similar project, but slightly different in that where the Kidney Information Network is all about patient-centered, it was co-designed with patients. Face Mums was more of a midwife-led initiative, which was around midwife-moderated, private, localised Facebook groups, providing additional antenatal support for pregnant mothers in 12 NHS trusts. Each group had up to 20 pregnant women and 2 qualified midwives. So yeah, the other project was Face Mums, which was a kind of series of midwife-moderated, localised Facebook groups. And what we found from that project was that those were successful in meeting the information and support needs of pregnant women and newly delivered mothers by improving continuity of care, providing access to midwives and facilitating peer support in a safe and manageable way. And then the other study that I want to draw on is one that Kath mentioned at the beginning, which is a study of sex edutainment that looked at analysis of over 60,000 YouTube comments on sex edutainment content made by influencers, and that then combined with surveys with young people and interviews with influencers themselves. and was looking at understanding the potential that they had, whether there was kind of benefits or negatives to that form of information, and then in kind of understanding what came from it. And what we found was that sex entertainment content had the potential to act as kind of the influencers to act as peer educators, with the videos being valuable spaces for sexual health learning, and a supportive and open digital space of communication around sex and relationships. But that there were challenges with YouTube restricting and removing the content. And some of the things that we're talking about today also relate to some ongoing training and development that I do with digital skills training for nurses. Okay, so why digital? Healthcare systems around the world are increasing their focus on digital strategy with the intention of making healthcare safer, data-informed, person-centered and efficient. Also, there's a real emphasis on enhanced communication between service users and healthcare providers, as well as digital enabling self-management for patients and service users themselves to take control of their own health. Next slide, please, Paul. And so I was really interested to have a look at what your national digital health strategy is in Australia. I can see that you can see that really fleshed out in the strategy for Australia around having digitally enabled, person-centered, inclusive and data-driven outcomes for the health system. And that this is kind of intended to be driven through change enablers that include, policy and regulatory settings. Then, having secure, fit for purpose and connected digital systems, informed, confident consumers and carers with strong digital health literacy. But the one that for me we're going to focus on today is a digitally ready and enabled health and wellbeing workforce. Thank you, Paul. Next slide. So, drawing on the work that we've done with health professionals and that digital capabilities work, what we've learned so far is that many health professionals have the core digital skills necessary to enact, digital change in the healthcare service. They just might not realise it. Personal use of technology was really high amongst the people that we interviewed and engaged with. They just may not have realised how transferable those skills were. A really interesting example from a workshop I ran was I was talking to someone and we were asking them, have you tried these technologies, those technologies? And I said, have you ever tried VR? And I had the person with the most visceral reaction immediately went, no, not for me, that. I'm not keen. I'm not interested in that. I think it's all a bit, no. And I was like, no problem. And then we carried on and I asked, what technologies do you have at home? And she said, well, I've got a computer. And she said, oh, and I really like doing driving simulation. So I've got the kind of chair and I've got the steering wheel and the screen. And my husband, he's into flight simulation. So he's got lots of screens and a whole flight simulator set up. And I said, that is VR, don't you? It's a slightly older version of the same technology. So actually, I said, you know more about VR than me. You're way more experienced with it, but you've just been using a slightly different type to what we now get with the goggles. So actually what we found was that people already had the skills, they've just never really thought about applying them in the workplace in the same way. And so in some senses, their confidence lacked in the workplace in particular because of that. We found that healthcare professionals were motivated by the benefit to their patients, less so about efficiency and money saving. Really, so many times it came down to, I just want what's best for my patients. If you can tell me why this is going to help them, then I'd be willing to get on board with learning how to use something. Participants largely felt that it could be used to offer valuable opportunities to improve patient care and tailor healthcare to the individual. As one participant stated, I see digital as an enabler. Almost all of our participants had positive feelings about the future of digital technology in healthcare. The majority of them felt technology can make workloads more efficient and have the potential to make their working lives easier, although in practice they experienced barriers to accessing these benefits at present. One of the things that was most important to pretty much everybody we spoke to was ease of use of those technologies. They want intuitive systems that are easy to use, but noted that making the switch to new systems still comes with challenges. As one person said, I think people think that digital makes things easier, which I think in the long run it does. At the beginning, there's a massive upheaval in order to achieve that. And so people really talked about that, and I'll give some examples in a moment. But another interesting thing was that most of the healthcare professionals weren't thinking about the use of digital outside of a direct clinical environment. So for the most part, they were thinking about electronic patient record systems. What does AI mean for reading brain scans or for doing other types of work, and other digital clinical tools that could be utilized, but rarely considered how they might engage in prevention and education work for service users using digital technologies. Next slide, Paul. Thank you. And one of the things that came out really strongly in that study was that successful digital innovation needs supported healthcare staff. So it's all very well for us to say health professionals need to improve their digital skills, but actually what they really, really need in order to do that is a strong and secure technical infrastructure, a solid implementation strategy, and high quality training and support. Next slide, please. So when it came to technical infrastructure, we had so many of our interviewees tell us about challenges they had with that. For example, one participant said, I think technology should make our lives easier, and I think there's a huge potential for it to do that in healthcare. I don't think we're probably embracing it at all because I think we have so many frustrations with the basic technology we've got not working. Another highlighted that they had to really fight to get proper mobile phones for their team in order to deliver the service that they wanted to deliver, and highlighted that up until 6 months ago, we had those little Nokia bricks that drug dealers use. And another person highlighted, for example, that actually, even beyond the devices themselves, having enough plug sockets in rooms was causing a problem. That actually there's supposed to be multiple outlets within patient rooms, however the majority of them are broken. So there are certain rooms where you have to choose between having the computer plugged for access or the observation machine. The majority of the time we choose the observation machine so we can track the observations in real time. Then that computer becomes non-functional. It's just these little things, but they really, really do affect the day-to-day. So actually, it wasn't in many cases that health professionals were not keen to embrace digital technology, but the infrastructure they had was not supporting them. Next slide, please. And that also led into having connected systems. And I saw that reflected in the Australian strategy as well. And I think that really became so important. In the UK, different trusts use different systems and you can't access information from other systems. And that was a problem, for example, in the neurology team, because actually that service worked across multiple trusts. So people was highlighting that they couldn't access files they needed when they were with a patient, and having to explain that the patient doesn't understand why I don't have access to what medication they're on, but it's on a different system. I don't have access to that system. As one person said, patients can't believe that in 2023 that the NHS hasn't got a computer system that talks to all the different hospitals, but they don't. GP land is another place where we don't talk to them either. Someone just needs to sort it out, but it seems to be too big of a problem to sort. So you can see that actually for a lot of clinicians, there was a real frustration about this aspect of trying to embrace digital technology in practice. Next slide, please. But in addition to this, it was also about how technology was implemented, and how that's communicated is really, really important, particularly the benefits. So I'm going to read you one quote that for me was a really, really good example of this. So one of our interviewees said, I think I would like a say in what technologies are brought in, because quite recently, all of a sudden, these like boxes got put on the ceiling, and there's some kind of something track, penny track. In America, they already have it. So nurses wear some kind of device or badge, and then it tracks where you go on the ward. So it knows if you've gone into that bed area, it knows if you've, left the ward, gone to the loo, gone to wherever. And then that was seen quite negatively, because it's almost like a trust thing then. Not that anyone's doing anything wrong, but what other job do people literally have tracking devices on them to do? So that wasn't great. We weren't keen about that. And then we were told that it was to track equipment, but none of the equipment had any of the tracking stuff on it. So yeah, I don't think that was very true, was it? But yeah, that didn't go down well. what's really interesting about this example is that I happened to talk to the chief scientific officer of a different NHS trust and mentioned this, and he said, we're about to buy in that system, you know, but he said it's not about tracking the trust of the staff. He said hospitals are massive. It's really hard to find people when you need them, or to work out, oh well, I gave so and so that piece of equipment, I'll ask them where it's gone. So the reason why he said it will save us hundreds and hundreds of hours of people looking for other people around a hospital to be able to find that out. But it turns out that in this case, it hadn't been communicated to the actual end user staff. And so what they felt like it was something that was tracking them, that didn't, you know, they weren't being trusted. That really highlights why that implementation is so important. Next slide, please. And then finally, there was a real importance on training and support. A lot of the clinical staff we spoke to felt that they hadn't received support necessary to use the software that they were being given. As one person said, I've had to embrace all these new systems that I actually find quite hard, because it's lots of new systems and nobody sat down with me and showed me how to use. Whereas I think in the past, someone would have shown you or come to your desk and shown you. Now you're just expected to get on with it, and there's so many. So actually there was quite often a feeling of not being supported by the organization, whether that's through, you know, high quality training and support, or through things being explained clearly, or having the kind of right kind of devices. And I think it's really important when we talk about digital readiness and embracing that change, that it's not just about the end user and saying you have to get on board with improving your digital skills. You also have to have a system around you that supports you to do that. Next slide, please. But we did note that health professionals did have some concerns about embracing digital technology in practice. Those included de-skilling the workforce, and concerns that digital technology and AI might de-skill them of the kind of core competencies that make up their role. And in some wider discussions with health professionals outside of this study, we've also noted a lot of concern about technology making jobs obsolete. There also were concerns about digital inclusion. In our interviews, participants mentioned that patients with epilepsy, learning difficulties, older individuals, or those without access to devices or the internet may be excluded from digital innovation. And then also concerns about navigating social media risks. And what that might mean in terms of access to misinformation, and also being on social media is risky for healthcare professionals in case patients try to contact them, or they might get struck off for saying the wrong thing. Next slide, please. So what's interesting when we think about that concern around de-skilling the workforce, there's a sentence that I say whenever we teach our students, which actually came from a conversation with a colleague, which is, digital technologies are not going to take your job, but people who are willing to engage with digital technologies will take the jobs of people who are not. And as we move into more and more digital innovation in healthcare, being willing to get on board with digital will become more and more important. Be more and more important that we're including training right from the starting point of careers as well. But embracing them won't put you out of a job or necessarily de-skill you, because it takes knowledge and skill to get the best out of technology. I don't know if any of you have ever used ChatGPT, but what I have found is that looking at it helps me realize the knowledge that I have, because I can see when it's not quite right. I can see where it's made things quicker for me, but where it actually needs things to shape and change and be worked on. And that level of skill and knowledge that health professionals provide will be essential in making sure that digital technologies can be applied practically and efficiently within healthcare systems. And using technology can also provide opportunities to expand and develop your professional practice and skills, which I'll talk about in a moment. But there's also kind of a tough question to grapple with here. A colleague of mine has written a fantastic paper on this. It's in the links at the end of the presentation in case you're interested. But if technology can do parts of patient care in a way that is safer or that enhances patient dignity, is it ethical for us not to be using those methods in order to protect our own skills? So it's a really interesting paper that my colleague wrote, really getting to grips with that question around nursing robots that are used in Japan. But it's a really, and when he talks to students, they're often very like, no, no to nursing robots. We don't want them. But actually, it raises interesting questions for us about, if you're putting patient-centered first, if patients prefer technology to being dealt with by a human, then actually is the best thing to sometimes be able to say, is it more important to embrace what's best for the patient than what's best for me? Next slide, please. Digital inclusion, as I mentioned, was a really important aspect. And it's a really valid concern that clinicians should absolutely have on their minds at all times. Anything that we introduce digital-wise, we need to think about, who does this help? Who does this exclude? But what's interesting, I think, is that we have to be cautious not to accidentally create digital exclusion through assumptions about who is and who is not able or willing to use technology. So a really interesting example of this was a recent study done in 2023 by Chowdhury and colleagues based in the UK, found that more than 50% of respondents aged 65 and over would still value the opportunity to use health apps. But only 7.7% of those willing to use health apps are currently recommended them amongst that age group of 65 and over. The author suggests that this is because the age-dependent increasing likelihood of having never used a health app was linked to a lack of recommendations from healthcare professionals as patients age. So actually, there are people who are willing to, but health professionals might not recommend them to older patients because they think, oh, they're older, they probably can't use technology. But actually, they may well have the skills and ability. So what's important is making sure that we offer those for people who want them and can use them. We don't make assumptions about who can and can't use certain types of technology. And in conversation with the same chief scientific officer of the NHS Trust, I asked him about his feelings about digital inclusion. And he said that in his intention, the aim of kind of really creating digital hospitals and digital environments was about making avenues available to service users who can and want to use digital systems and tools so that they can free up significant amounts of time to ensure that those who cannot or do not are more readily able to receive in-person care. So it's not about replacing in-person care, but what it is about saying, well, if you want to use digital, we've got a system that allows those who can to get through quicker and smoother. So then that frees up more clinician time to deal with backlogs and with people who actually want that face-to-face connection. Next slide, please. And then on social media risks, what we found was that many of the healthcare professionals we interviewed use social media for personal use, but only a few utilize those platforms for professional use. And often this was having a kind of a LinkedIn profile as opposed to doing anything that was more involved in care-related work. The majority were not considering how they might use these technologies for patient benefit or to develop their own practice. And what we found when co-designing a social media intervention recently with healthcare professionals was that there was a lot of fear about misinformation being spread or the difficulties in maintaining those kind of professional boundaries in online spaces if patients were in them. Next slide, please. But there are some benefits to engaging in social media as a professional. One of the main ones is the opportunity to provide support, prevention, and education. People need different types of support and education to take proactive care of their health. This can include peer support, like I mentioned with the Kidney Information Network and the Face Mums projects, where actually they want to exchange and discuss lived experience. One of the things that we found in the sex edutainment study was that the questions that people were asking on those videos are not the ones that they would get answers to on our NHS website. They were actually questions like, you know, should I take my glasses off during sex when I have it for the first time? How do I make my trans partner feel, you know, less body dysmorphia during sexual encounters? Things that we just would never normally put up on a healthcare website, but that do impact young people's feelings around sexuality and around their confidence during sexual encounters. But also, healthcare professionals can be part of these exchanges to provide clinical reassurance about information accuracy. That was really the main role in Face Mums of the midwives who participated, was to engage conversations, to share information in an accessible format that could be accessed on evenings, weekends, whenever you wanted to. You wouldn't have to try and, call up your local service if you had those kind of small questions that weren't pressing or urgent. And they were also able to, say a pregnant woman said, "Oh, I've read this about eating 7 pine nuts a day will make my baby a boy. Is this true?" Then the midwives were able to fact check, correct, provide evidence-based information in those spaces. Social media is also great for understanding patient experience. It gives you insights into the lived experience of patients. A nurse that we interviewed for the digital capability study told us that she had a patient with a very rare autoimmune condition, and that patient happened to mention that it ran in the family and that they had a sister who also had the same condition, and that sister had a YouTube account where she vlogged all about the experience. And this nurse said that I went and I watched those videos, and she said, "I learned more about that condition from that YouTube account than any medical textbook could ever have taught me, because there's not enough about the lived experience of such a rare condition." And so that then meant that it informed the care that I gave her sister, because I understood the experience of what it meant to come in with that condition. And she felt that had really improved her professional practice. In addition, being aware of misinformation trends online can help you prepare evidence-based responses when these topics end up in the room with you with patients. So, a good example of this is, with COVID-19 and the 5G conspiracy, that actually, if you're aware of what the conspiracies are online, then you can prepare yourself evidence-based responses so that when those conversations come up, you can influence and have conversations that are informed, as opposed to being kind of blindsided by what is brought to you sometimes in your clinical practice. And then there's also opportunities for expanding best practice, whether that's through engaging in communities of practice where you can exchange information with other professionals in your field, or engaging in other forms of social media networking. And overall, I would say, when it comes to social media, engage, but engage with care. Digital professionalism is really, really important. But actually, those spaces aren't ones that just necessarily have to be feared in entirety. Next slide, please. And so, as a kind of example here, from that sex edutainment study that I mentioned, in this example, we can see that young people wanted digital resources, but were largely dependent on what the Google algorithms threw up. They were also concerned about misinformation in online spaces and if they could trust the influencers who created the content. But there was also examples of it being really, really beneficial. So people commenting on the videos largely received real value from it. But because YouTube limited content, it was blocked from the view of under 18s, even when it was created for that age group. And the algorithms made it hard for those over 18 to find it. But what we noted was that in some of the comments, nurses were discussing how they were signposting their service users to the content because they thought it was valuable, or they were using that to inform discussions that they were then having with the people that they worked with. And I think this is a really nice example to show that for healthcare professionals, even if you don't want to make content yourself, you can still be instrumental in fact-checking, verifying, and signposting content that might appeal to the patients that you work with. Next slide. And so to kind of round us up towards the end, I just wanted to kind of highlight that you are the perfect digital innovator. Many of our participants, especially nurses, felt that digital innovation was nice, but not their job. But the best digital innovation is led by those on the ground who truly know the needs of the people that they work with, not by a techie in a Google office who's never ever stepped foot in a hospital or in a community setting or in a sexual health clinic. You know the challenges that hold up communication, the issues faced in clinical practice on a daily basis. You have knowledge and skills that can shape the future of digital health. And there are many ways to be involved with innovating healthcare in the digital space, and you don't need to be a super user of technology to be part of shaping them. I know a nurse who is now works in kind of digital based nursing education, but she went on that pathway because she was in clinical practice and there was something really niggling her in her practice. And she said, you know, if we got iPads, we could make this whole process much easier and much quicker. So she wrote a business case for her trust and for her ward to buy in some iPads and to trial it. And it was really, really successful and made a real difference. And from there, she wasn't, you know, some great technical whiz. She doesn't design apps. She just thought, this has got to be quicker with this other thing that I use at home. So there are lots of different ways that you can be an innovator when it comes to digital without being a techie yourself. Next slide, please. And so what does that mean for having a finger on the pulse when it comes to digital technology in health? Digital innovation is ongoing and continually expanding. It's completely normal to feel a bit overwhelmed by the change of technologies in health. However, you may already have some of the core digital skills that you need that can be applied to your work. In order for successful implementation of technology in healthcare, healthcare professionals need to be supported with a strong technical infrastructure, well-instigated implementation strategies, and quality training. Also, healthcare professionals have valid concerns about digital, and it is their role to be skeptical on behalf of the people they care for. However, it is important to let these guide your digitally enabled practice rather than resist it entirely altogether. Also, don't be afraid to expand your professional use of digital technology outside of electronic patient record systems, and consider how you can use things like social media in your practice when it comes to, you know, education and prevention work, especially. And then finally, you know, my big call for you all is think of yourself as a digital innovator. How can you improve practice in your area by utilizing digital technologies that you already know how to use? Next slide, please. Thank you very much. That is everything for me. I've included some QR codes on the screen to some of the reports and papers that I referred to during this, if anyone would like to have a look in a bit more detail about them.
Fantastic. Thanks so much, Lisa. And amazing MacGyvering of the various dramas we encountered with two-stage verification on an international SIM card. Who knew that was going to be such a hurdle? Folks, we would love your questions through the Q&A. While we're waiting, though, I wonder, Lisa, there's lots of directions we could go in, especially with such interesting papers, but I wonder if you could speak a little bit about your PhD study, which is the part of your work that I know the most about, the YouTube influencers, how you came to it, and what you think the significant findings were in relation to a space which I know causes a lot of consternation, particularly in Australia right now, questions of young people encountering health information and other kinds of content online, and what the impact of that might be on them. How did you what kinds of work did you do for that project? Can you give us the potted version of your key findings, please?
Of course, yeah. So I came to that study from I'd actually done a previous study in my master's looking at parent and teacher perspectives on sex education and on digital resources. And what I found was that in both cases, they were desperate for more resources and more support to enable them to have conversations. And through that, the idea of social media resources and particularly YouTube videos came up. And other prior work, including work that Kathy, yourself, have been involved with around looking at, you know, edutainment as a form of education, but also how that is spread, and the possible spreadability of YouTube led to YouTube as one of the key areas to look at. And what for me was really interesting out of that study was that actually there is lots of opportunities to engage in this sort of this sort of, you know, education, and it seemed to be that the people who were engaging with it were really, really keen for it. There was very positive response to it overall, occasionally negative, but actually the biggest negative response to the YouTube comment on the YouTube comments was not, you know, this is misinformation, because it wasn't. There's only one example in the videos that I found where someone had referred to something as being a bacterial, but it was actually viral infection, you know. But otherwise, you know, a lot of there was no real issues with any of the content, and that wasn't what people had issue with. When people had issues, it was, you shouldn't be talking about this, it's inappropriate. So interestingly, those same challenges we have in school environments, and that same challenge was also fed through in terms of how YouTube responded to some of the content. They use algorithms, obviously, to manage a lot of content. Algorithms find it quite difficult to work out the difference between something designed to educate and something designed to arouse when it comes to talking about sex. And so one of the biggest challenges around that work was, how do you get it to people? Because it's helpful, there's value there, there's needs in terms of particularly information needs for young people who felt like when it came to intersectional needs, you know, whether that was sex and disability, LGBTQ plus, you know, young people, etc. That was where there was a lot of, you know, those were the places where it was strongest, the need and the response around the content. But what was interesting was that obviously then they're finding it hard to access content because of YouTube. And I think for me, one of the big kind of, and this is a next step for me on this work, is how do we get this sort of content out to young people? And I think one of the ways is probably utilizing health professionals in order to verify the content. You know, I actually been umming and ahhing about whether or not do we develop a digital platform where the videos can be hosted off of YouTube by influencers, and you get a health professional who does like a mini review at the side that says, you know, I'm a sexual health nurse and I verify this information is clinically correct, but you might want to consider that this video talks about XYZ, and this might not be, you know, you might need to consider it this way, or this video was sponsored by Durex, so it highlights condoms, you know. And I think that actually those trust mechanisms that young people have in health professionals and people with that experience being able to say this is correct or this is misinformation, I think there's real opportunity to explore that further in future work. So for me, I think that's where, you know, there is an opportunity for health professionals to be involved in, even if they don't want to create content, because let's face it, content creation takes a long time, it's a lot of effort. If people want to do it, then amazing, that's absolutely fantastic. But if they're not sure, then actually I think there are other ways to signpost, to, you know, check and be part of those information ecosystems that don't involve having to make it yourself.
Yeah, that's fantastic. Thanks. Paul, would you mind unsharing the slides so we have a bit more face back on the screen? Awesome. Thank you. Anyone in the audience? I know it's difficult because on this format we can't see each other's faces, but please do drop a question in the Q&A or hit the raise hand button if you would like to ask a question about a bunch of really interesting projects. Lisa, I was really interested again. I will carry on. I was interested again in some of that pedagogical work where you've actually done training with nursing students in the classroom, and particularly those conversations about digital professionalism. Can you share a little bit more about the kinds of conversations you would have in, I guess, a pre-service or an in-service conversation about this work? Because often we talk about that in an abstract sense, but you would have a sense of what the concerns are on the ground, and particularly through the course of a semester, for example.
Yeah, absolutely. So a lot of what we talk about when we do the kind of digital capabilities training with our nurses, and especially around, you know, digital professionalism, is things like being aware of your digital footprint, you know, going back, and when you're moving into practice, going and searching yourself on Google, finding out what's available about me, utilizing things like Right to Be Forgotten, and things like that, that you can utilize through Google to say, I don't want this associated with me. I've done that myself with something. I once did a news article about my cheap wedding, and then it got associated with my name, and it was with the Daily Mail, which in the UK I do not have positive feelings about. I didn't get to choose the newspaper that ran the story. And actually, when people were searching my name as an academic, that was coming up really high in the searches. And I thought, I don't want everyone to know how much my wedding cost, actually. So I went through that, but I had done all of those searches myself to see what comes up. Actually, is there some weird, obscure photo of me that looks very unprofessional that comes up if I search my name on Google Images 3 pages in? All of those things we encourage our students to start with and the professionals that we work with. But then a lot of it is around things like thinking about the grey areas, because I think certainly in the UK, our National Nursing and Midwifery Council, who are our kind of registration group for nurses, they have a very, don't post the wrong thing on social media, you'll get struck off. And what that does is create a lot of fear about using social media at all. So what we do is encourage people to think about the grey areas, WhatsApp chats. How do we engage in a WhatsApp chat professionally? How do we vent after a bad day to our colleagues in a way that's still professional, but gets what we want out of it at the end, which is support and understanding? So we have a lot of conversations with students around those sorts of things. But also acknowledging things like, just because you think that you're anonymous in a space doesn't mean that you can't be tracked. There was a case in the UK of a midwife who believed she was on a kind of anonymous gossip forum about influencers, and she happened to also be an influencer herself. And she said some things that were not good, let's just say. And then people were able to work out that her IP address was in the same location that she had been posting on her Instagram. She was linked together with it, and then lots of people made complaints to the NMC saying she should be struck off because she said these things and they would impact, her ability to work with people. So we highlight that, it may be anonymous, but someone might print screen it. If you wouldn't say it in front of your boss, then you probably shouldn't say it in online environments. But also encouraging people to see that there are lots of positives in those spaces. It's just engaging the same way you would if you were in a clinical space face to face. If you wouldn't engage that way in a clinic room or in a community setting, then that's probably not the way that you should, behave in online spaces, which can be frustrating because everyone else is behaving however they want, but in professions that are healthcare professions, there is an awful lot of pressure on you to represent your profession, even when you're off, work time. So we do kind of engage in those discussions and those ways of being kind of digitally literate, but not necessarily saying don't go into these spaces. Just use them, but use them with caution.
Fantastic. And finally, one of the things that we found in our recent work with 18 to 29-year-olds using digital media was that it was not always the influencer video itself. Sorry, I'm jumping back to your influencer research. It was not always the influencer themselves that was the helpful or supportive part of the online engagement for them. It was the comments underneath that affirmed shared experience. And so the example was people in our workshop talking about wanting to know more about the experience of having an IUD inserted and how people experience that as painful or as not too bad or those kinds of things, and that the shared dialogue around that experience was what was useful for them. I wonder if much came up for you in your research, not so much about the content of the influencers, I guess messaging, for want of a better word, but the camaraderie of the comments.
Yes, this actually ended up being a really, really big part of what was found in that study, was that influencers are not responding to every single person who comments, but they are inviting a culture for people to engage in conversations openly about these things. And even when the influencer wasn't saying, tell me your story, people were telling their stories. You've got a video about virginity. people are telling their stories. Well, this was my experience. That was my experience. I had the same thing. Or people were asking questions, probably intending that maybe the influencer might answer them, but actually other users were answering them and giving advice and giving suggestions, or just supporting each other. And I think that actually in this kind of work, that's really quite an important and valuable thing, because we do not necessarily have face-to-face cultures where people feel comfortable talking about these things with their friends, with their families, with their educators, but having a space where you can talk openly and feel like, you know, you can speak about whether or not something is, you know, for me, the example of should I take my glasses off during sex when I have sex for the first time was a really interesting one, because I thought, you know, you wouldn't ask your sex ed teacher, you wouldn't ask your parent, probably, you know, and you might not want to embarrass yourself in front of your friends, but that's for someone who's not sure. The idea of embarrassing yourself the first time you have sex is mortifying. Like there can, you know, no worse feeling than doing the wrong thing. So it's still important, and having a space where that can be asked anonymously and people can talk about it, you know, gives people a different level of comfort and ability to explore things. And I think actually for us is a real learning about what people's information needs are. And they're not necessarily, what's this STI, and, you know, why does it burn when I pee? Those sometimes, yes, those questions were also asked, but actually a lot of those questions are much more nuanced and much more about lived experience, and trying to understand, you know, okay, well, this person's experienced that one's experienced this, maybe I'll be okay when I do, etc.
Yeah, it's such an interesting balance, isn't it? Because we are seeking health expertise, but the space of lived experience, as we know in healthcare itself, is becoming increasingly recognized. But the space of lived experience is so essential to our feelings of well-being or safety in relation to our health, which is, as you say, a bit more nuanced than, you know, what is this bacteria? What is this symptom? Where can I get screening? Which are all important questions, but yeah, it's a different experience, isn't it?
Yeah, absolutely.
Okay, well, if we don't have any questions in the Q&A, I think I will say thank you so much, Lisa Garwood-Cross. We really appreciate you joining us and persevering with the challenges of the tech. We made it work in the end. Thank you very much to Paul Lavey and the rest of the Swinburne support team. Yes, for folks who have registered for the event, there will be recordings shared as well, and transcripts. So there'll be a chance to look over the information. And I'm sure Lisa would be very happy to share prints of articles, or also information on the curriculum and other aspects of the research that she's been doing in terms of both the sexuality educators, but also the nurse education and the digital capabilities work. Thanks very much.
Thank you so much.